Today we are going to talk about palliative care in geriatrics, and we have an eminent faculty, uh, and presently she is working in Mass General uh, Bergen Benford Douglas Hospital in New Hampshire, USA. She has done her MBBS from Father Muller's Medical College, Karnataka, and she did her internal medicine residency from University of Miami and veteran affairs in West Palm Beach, Florida. And then she did a 2-year integrated fellowship in geriatrics and hospice and palliative medicine uh, from School of Medicine at Mount Sinai. And that's #1 ranked hospital in the US for both of these fields. And leadership of Dr. Sean Morrison, and now she's working in a rural
Sir? Oh.
And completed her shift from CATC. Audible? Priya?
Sir, I think I lost you for a moment there, but I'm not sure whether it was same for everyone.
Okay. But
Sir,
can you mute them?
Yeah, I muted, sir. You can continue.
Okay. So she has completed her leadership from CAPC, American Geriatric Society, and then Harvard Massey leadership courses. And her areas of interest are quality improvement, medical education, and expansion of general inpatient hospice and geriatric care in her hospital to help create an age-friendly system. She has learned Indian Carnatic music, piano, and sings at local church choir. She loves music therapy and has a YouTube channel. And probably, I hope at the end of the session, we will hear a song from Dr. Rosmy. Welcome, Dr. Rosmy, and it's over to you.
Hi, everyone. Thank you for that introduction. Nice to see everybody in this group. I will start with sharing my screen. 1 second. Please let me know if you can see my screen. Are you able to see my screen, everyone?
Yes, it is very visible.
Okay. So basically, yes, these are all the places that I've worked and I finished after my medical school. I gained a very interesting perspective in India when my grandfather had cancer in non-Hodgkin's lymphoma, and my grandmother has dementia. And I found that in India, this is something that really needs to come up. There's not, I'm still surprised there's not really as far as I know, there's not many geriatric fellowships, and I don't know if there's an accredited palliative care fellowship, but there's about 6 integrated programs in the entire country in US, and Mount Sinai is one of them. So I'll start with so I have no disclosures, no financial.
Your voice is very low. We cannot hear though.
Okay, can you hear me now?
Yeah, now you're, yes, correct.
Yeah.
Thank you.
If somebody can just monitor the chat for me, I don't think I can manage the chat also. So just let me know, ask me if there's any questions on the way. Okay. So the objectives of this talk is to discuss the significance of integrating geriatrics and palliative care, to understand the 5 M's geriatric principles in the care of older adults, and to create an evidence-based approach to diagnose and management of common geriatric conditions. So what is the definition of geriatrics? It is a medical specialty that focuses the diagnosis and treatment of diseases and problems specific to older adults. There is no defined old age at which patients can come under the care of a geriatrician. So what does old mean? Old can mean, according to United Nations, it's 60 years. According to CDC, it's 65 years. In America, it is 65 years, but it can be, a healthy old person can be 75 years. So really, it is a relative term when it comes to old. And in fact, we are going away from using the word older, according to American Geriatric Society. Geron is the Greek term old, and iatros is healer. So the word geriatrics came from a Greek term that said old man healer. So why is geriatric important in palliative care? So the epidemiology here, I have tried to summarize a little bit of the statistics in the US and in India. So the world is aging at a very rapid rate. In 2030, it is expected that 34 nations will have about more than 20% of its population above 65 years. India, from 2011 to 2021, it's gone from 8.6% to 10.1%, and that is about 140 million people. So that's 10% of 1.4 billion people is 140 million people are in the older generation, older age. Expected to become 13.1% in 2030. This is the WHO consensus. In USA, it is 13%, which is increased to 16.5%, which is about 54 million people, and it's going to be 20% in 2040. So it looks like a small number, but it's actually a large amount of people that are becoming elderly. And this is most likely because of the advances in science, the early screenings, decreasing the prevalence, and at the same time, management of conditions trying to help people live longer. The life expectancy in India right in 2020, the latest is 70.15 years, and life expectancy in USA is about 77.28 years. Now, why is it important to discuss geriatrics in palliative care? So, as we just said, that the world is aging and we're having more and more elder people. Their care is very different due to the psychological changes in aging. It's an atypical presentation of disease and increased side effects to medications. There's increase in frailty, in comorbidities, in hospitalizations, even neglect, social isolation, debility, and decreased quality of life. This is a diagram in how you're combining both geriatrics and palliative care. So from screening and diagnosis is the beginning part of when you meet your patient. And then you're going from a curative intent, but then once you start the treatment, once you reach the progression of the disease, there is going to be a time where there is minimal disease-directed treatment options. And that is where that combination or that perfect intersection happens between geriatric and palliative care. And at one point, it actually leads to end-of-life care. So why integrate? It helps to meet the complexity because there is a demand for care coordination in elderly. There is shared decision-making. You need clear goals of care, and you need seamless transition to the community. There is actually an interesting paper, which was by Atria et al. In Journal of Family and Medicine Primary Care in 2022, September 11. And this was actually one paper that I saw that has an integration of geriatric and palliative care in India in the current situation and why this is actually the need is going up. So one is once you reach above 65 years, you have a very complex medical, diagnosis. They have a list of diagnoses, they have a list of, complex situations going on. Two is they have goals. There are clear, we need to assess their goals of care once they reach that age, because any emergencies can happen. We need to be able to respect the patient's wishes. Three is it prevents unwarranted hospitalizations. So hospitalizations, if you're clear with your goals of care, you can prevent them from coming to the hospital. Now, this is very hard to do, especially because this all falls on the primary care physician. But that is something that we hope that, why do they, this also reduces the ER burden, like this also reduces hospital burden. And then when they're older, when there's cognitive impairment, patients are not able to express their wishes. This also helps to maximize the quality of life in older adults, and this addresses caregiver burden because once it's like when it comes to pediatrics. In pediatrics, you're dealing with not only the patient, you're also dealing with the family. Similarly, in geriatrics, you're dealing with the patient and the family. So there is also some caregiver burden that we have to address when it comes to geriatric palliative care. It also improves patient outcomes and patient and family satisfaction. Now, when do we initiate this integration of geriatrics and palliative care? So there is disease-independent markers and disease-specific markers. Disease-independent markers are like frailty. What is frailty? Frailty is when they start having complex chronic conditions which decrease their independence. So there's functional dependency. They start getting dependent on activities of daily living and activities of independent activities of daily living. So it's ADLs and IADLs. So there's cognitive impairment, symptom distress, family support needs. So these are the disease independent markers. So when there is a patient that starts getting more and more frail, there is actually a frailty score which is out of the scope of this talk. So I would say if once they start progressing from the frailty staging, then there is also functional dependency with, for example, a walker, from a cane to a walker to a wheelchair. These are all signs that we should start thinking geriatrics and palliative care. Also, symptom distress. So when somebody's heart failure is becoming more and more advanced, they're going to have more and more shortness of breath. That is how you know that this is again becoming advanced to the point where we are discussing about palliative care. Whereas disease-specific markers are like symptomatic CHF, which is your, heart failure, congestive heart failure, chronic lung diseases like COPD or interstitial lung disease, dementia, there are different stages of dementia, stroke, cancer, recurrent infections and hospitalizations, degenerative joint disease with chronic pain and functional impairment. So these are just some signs of when to think about integrating geriatrics and palliative care. Now, not everybody who grows old or above 65 is considered, abnormal. So what is normal aging? This is important for us to differentiate when you see a patient. So in the normal aging process, yes, there's decrease in the CNS, there is decreased axon neurotransmitters. So they're slower in normal aging. With cardiac output, they have decreased artery compliance. So they have aortic sclerosis, heart failure, increased risk of hypertension and stroke. With pulmonary, there is decreased thoracic muscle compliance and strength. So they have decreased exercise tolerance. With renal, they have decreased renal function. So they do have chronic kidney disease due to hypertension, diabetes, heart failure. So CKD alone does not happen with aging. CKD usually happens in the setting of hypertension, diabetes, or other conditions that are causing chronic kidney disease. Urinary bladder, there is decreased bladder tone, so they start having urinary retention and incontinence. Musculoskeletal, there is decreased muscle mass with aging, so that increases the risk of falls, osteoarthritis, and hip fractures. With vision, there is decreased lens flexibility, which is also called presbyopia. So this is normal in aging. And auditory is sensory neural hearing loss, is presbycusis, which is also a normal phenomenon of aging. Now I want to introduce, so now that we went over the understanding of geriatrics and how it affects or why it's so important, and then try to integrate it with palliative care. Now I hope that from these few next slides is going to talk about the geriatric 5Ms. So this is the fundamental 5Ms of geriatrics, which was introduced by Mary Tinetti et al. In 2017. This is what we follow in America. And it is here, whenever you want to try to make a hospital age-friendly, they follow these 5Ms. It used to be 4Ms, and they added the 5th M called multi-complexity. So the 5Ms include mind, mobility, medications, multi-complexity, and what matters most. If you think these 5Ms for all your patients, then you will be successful at trying to address the most complex situations in geriatrics. So let's talk about the first M, mind. What comes under mind? So the mentation, dementia, delirium, and depression. These are the most important components of the mind. And this is from the American Geriatric Society, this picture. It's very classic picture. It will be there in almost many studies also. It's the two hands. So dementia. What is dementia? What is the definition of dementia? It is a chronic acquired decline in one or more cognitive domains, including learning, language, memory, complex attention, executive, which is sufficient to affect daily life. So what's important in this, that it is not just memory loss. A lot of people think, okay, there's memory loss, and so that is dementia. No, it has to affect your daily life and in any of these domains. Some types of dementia, most common cause of dementia, almost 50% or more is Alzheimer's dementia, where memory loss is one of the first signs, where patients can start repeating themselves, or patients can get lost where they're going. They forget their keys. There are things that are affecting their daily life, and it is becoming more and more advanced. That is few symptoms of Alzheimer's dementia, the most common, and also the most underdiagnosed. The next one is vascular dementia. So vascular dementia is seen like in a stepwise decline. This is a classic board question that we get, like, how is vascular dementia different from Alzheimer's dementia? Vascular is like they are fine, and then they suddenly deteriorate, and then they get better, they're stable, and then they suddenly deteriorate. That sudden deterioration is classic of vascular dementia. You see this in patients with stroke, with atrial fibrillation, with heart failure, or coronary artery disease. Basically, a vasculopath has a very high risk of vascular dementia. Parkinson's dementia. So Parkinson's dementia most likely has the features of Parkinson's, and usually they have the clinical features of Parkinson's before they end up with dementia. There's Lewy body dementia, which has visual hallucinations. So that is how you differentiate Parkinson's dementia from Lewy body dementia, because Lewy body has visual hallucinations. Frontotemporal dementia, it is also called Pick's disease. They're very agitated, and they have very classic frontal, which is behavioral disturbances. There is also a reversible type of dementia, and then most of the dementias that we are talking about is irreversible. But dementia is when we say it's reversible, it is usually vitamin deficiencies or medication induced. So basically, they present with dementia features, but when you do the regular testing, you find that this can fix the problem. What is the difference between dementia and mild cognitive impairment? Has anyone heard what is mild cognitive impairment? And I don't know if anybody can answer that question. Is everyone able to hear me? Sorry, I'm just making
Yeah.
sure.
I'm just guessing, ma'am. I'm not
Yes.
sure. Dementia involves the all components of the memory, whereas in mild cognitive impairment, it's only the cognitive part which is
Yeah.
impaired.
Yeah.
No, I'm not
So
sure.
yeah, so that's almost right. Yes, because so the difference between mild cognitive impairment and dementia is that mild cognitive only affects the cognitive part. Dementia affects all the activities of daily living. So when there is functional component difference, so for example, they start had difficulty walking, there's difficulty eating, there's difficulty driving the car, difficulty going to the bathroom. Like these are things that are more, you know, more suggestive of dementia, not just mild cognitive. Cognitive alone is not dementia. So the next thing is, what's the difference between dementia and delirium? Can anybody answer that?
Delirium is the state of consciousness level, whereas in dementia, that is not
Yes,
the concern.
exactly.
Yeah.
Exactly. So delirium is a state of point in time. It is usually acute, whereas dementia is chronic. So dementia is chronic. So when somebody comes to you for the first time, a patient is coming to you and they're like 70 years old, they're coming completely confused. How do you differentiate between delirium and dementia? They can present very similarly, right? But the difference is that you want to know what the baseline is. So a baseline is the most important, because if somebody's baseline is, walking, talking, and suddenly there's an acute change in their mental status, that is most likely delirium. Now, it can also get more complicated when there is delirium in the setting of dementia. So this is just important for us to understand, because delirium and dementia can increase morbidity and mortality. It is important to screen once every annual wellness visit. So how do we screen? So now moving forward. So first of all, when you see a patient in the clinic, this is the most important thing in geriatrics that you have to assess. So there is activities of daily living and independent activities of daily living. So out of all this, I have a question. What do you think is the first thing to go in a patient who is starting with early dementia? What do you think is the hardest thing to do out of IADLs?
Dressing, maybe.
Sorry?
Dressing.
So dressing is ADLs, right? So usually the way the course is that IADLs go away first, and then ADLs go away, because the activities of daily living are basic things like bathing, dressing, toileting, transferring, continence, feeding, right? But IADLs are more, require a lot more coordination, require a lot more executive functioning. Like stroke patients will have very difficult time handling IADLs, but they will be probably able to do ADLs. So the first
Handling
ADL,
finances. Handling
sorry?
finances.
Exactly. Yes. Yes. That is actually very correct. So the first thing to go away is actually handling finances. So when you start that they cannot handle their own finances, and this is very important because they're usually, like, if somebody has never handled their finances and suddenly they're not handling it, it's not very different from their baseline. But this is a person who's been handling their bank accounts and their finances suddenly cannot handle their finances. That means we need to start assessing their cognitive capacity. So that is the first thing to go. What about the first ADL, or the most difficult ADL? Out of all the ADLs, what do you think is the hardest to do? Anybody?
Answering.
So it's bathing, actually. And no, not bathing. I'm sorry. It's dressing. No, it is bathing, actually. Yes, correct. It's bathing, because bathing requires dressing, right? There's required undressing. There is toileting a part of it. There's different parts. There's walking from one place to the next. There's continence. Basically, bathing includes a lot of the areas. So that is why bathing is actually the hardest, and it's usually the first thing to go. How do you screen for dementia? So there's something called mini-cog. So mini-cog is actually a mini, or I would say the first screening test that can be done in any clinic. It can be done in a hospital setup. It is basically a 3 test. So there's 3 levels to this. Okay, the first test is, I don't know if I took a, no, I didn't put a photo of this, but this is, we call this the clock test. So you would start with a 3-word recall. So mini-cog uses 3 words. For example, okay, I will tell you to remember apple, banana, carrot. Just 3 words. Keep that in your mind, and I will ask you about it later. The next thing is you ask them to draw a clock. So when you ask them to draw a clock, has anyone seen this clock before? Has anyone seen the clock of normal versus abnormal? So basically, it's a circle. It has 1, 2, 3, 4, 5, 6, the entire clock, right? It has to be in the proper, clockwise, right? It has to say 11:10, which is 10 minutes past 11 o'clock. That is a proper clock. So now you ask them the 3 words, then you ask them to draw a clock, and then you ask them what the scores are. So this is just a screening. Now, this usually in palliative care, you may not end up doing this because they are already so advanced. So they usually already have a diagnosis of dementia. So if it's 0, it's dementia. That means they're not able to recall anything. But if they're able to recall 3 words, there is no dementia. Then there is something called MoCA. I hope anybody has heard of MoCA versus MMSE. So MoCA is a confirmatory diagnosis. Dementia is a clinical diagnosis, but MoCA is used to help. 94% of MoCA is correctly diagnosis dementia. So has anyone seen MoCA before? I don't know if I don't think I have a MoCA assessment, but I can tell you that MoCA has different parts of it. First part is language. The second part is executive functioning. So you ask them to count like 100 minus 7s, and then you keep asking them to count 7 backwards. And then there's repetition, where they try to repeat the name. You tell them, okay, repeat these 5 words, repetition, naming. And then you also have a clock, even in MoCA. And all of this is a sum of 30. So total is 30. That is a MoCA evaluation. Even MMSE, which is mini mental screen exam, is also 30. So I would say MoCA, the biggest barrier. So now suppose if somebody has not done high school, language will be a problem, right? Education will be a problem. Now, another thing with language. So for example, if it's Spanish speaking, if it is another language, if they don't know English, how will we do MoCA? So that is a barrier, actually. And this is why these tests may not be relevant when it comes to different languages. There are some MoCAs that are in Spanish. So just remember, the most important thing is normal is about 26. Less than 25 is starting to be abnormal. And mini cognitive average is 21. Mild is 11 to 25. Moderate can be less than 10, actually. I would say 10 to 17 is actually correct. So moderate is about mild is less than 25, moderate is less than 17, and severe is less than 9. That was the typo error. But severe is, advanced dementia. Now, with respect to palliative care, how is this all relevant? Has anyone seen this before? Something called a FAST scale. This is in the US. This is primarily used to prognosticate dementia. So the way I remember this is the opposite of developmental milestones. So in a baby, what is the first thing that happens? They're able to hold their head up, right? The next thing that happens is they smile. There is exact reverse in dementia. So if you look at it, 7F which is the last stage, is the loss of ability to hold the head up independently. 7E is the loss of ability to smile. And 7C, they cannot sit up without assistance. 7D, sorry. And then 7C is ambulatory ability is lost. So I know that, obviously in India, it's different situation. We cannot compare India and US. But I want you all, one thing to get away from this is that when do you recommend or when do you say that when a dementia is advanced or end stage dementia? At what stage do you say that it's end stage dementia? Is anyone able to answer that?
The incontinence?
Yeah, incontinence is one of them. That is 6C, but it's not yet advanced. You could be sitting and talking and saying full sentences and still have advanced dementia, right? So the answer is actually 7C. So 7C is, so now they're already incontinent, they're already having fecal incontinence, urinary incontinence. But the classic is that they will not be able to speak more than 6 intelligible words. So a patient who has advanced dementia, their ability to speak will come down. They may not be able to say more than 6 words. They may repeat the same word again and again and again, but they may not be able to say more than 6 different intelligible words. So they lose that, and then they lose the speech ability. And 7C in America is a hospice eligible diagnosis where the ambulatory ability is lost. So they cannot walk without personal assistance. So somebody, for example, I'm giving you an imagine a patient who is like 85 years old, who has advanced dementia. They won't be able to talk. They won't be able to speak full sentences or even just intelligible words. They won't be able to ambulate without assistance. And they won't be able to sit up without assistance. They may not have a smile. They may be completely bedridden. These are all signs of advanced dementia, and advanced dementia is irreversible. There is no cure for advanced, or even there is no cure for dementia, period. So now this is very important when you come to prognosticate. Now, why is advanced dementia very important? Because the prognosis of advanced dementia or end stage dementia is less than 6 months. That is why it is a hospice diagnosis. So with regards to treatment, there is no treatment for restoration of mental function. The treatment for depression is important, SSRIs, because this will help to differentiate dementia versus pseudodementia, because pseudodementia is seen in, it is a controversial term called pseudodementia, but we should treat depression and see if it is reversible. You want to avoid anticholinergics like antihistamines or diphenhydramine or over-the-counter medications that can cause confusion. Now, agitation or behavioral disturbances. So agitation, behavioral disturbances is so common in dementia, right? What is the first line treatment for agitation or behavioral disturbances? It is non-pharmacological. So that means you don't medicate patients who are having behavioral disturbances unless they are causing safety issues. So if they are a harm to themselves, if they are a harm to the nurses, if they are a harm to, the hospital, if they are a harm to anybody, then you have to start treatment. So what is the first line in at least in our in studies for here has shown that citalopram, and that is actually at 10 milligrams of that. Sorry, this is 0. But 10 milligrams of citalopram is the first line treatment for behavioral disturbances. We can start as low as 5 milligrams, but we start with citalopram, which is an SSRI. We in the hospital also use low dose quetiapine, also known as Seroquel, which is 12.5 milligrams at night. So we use that as needed for behavioral
You can
disturbances.
just leave everything and
Sorry?
See the
Okay. So the next thing we see is Haldol. So Haldol can be used IV or IM. What to keep in mind with Haldol is QT prolongation. So for patients that are in the hospital, if you're starting somebody on Haldol in palliative or in geriatric, we start with 0.5 milligrams every 6 hours as needed. for agitation, we typically stick with IM or PO, which is intramuscular or by mouth, if they are if you're able to check the EKG for somebody who's not at the end of life. End of life, we use IV all the time. Then also risperidone. So risperidone or risperidone is basically an antipsychotic, which can be used in the sake of schizophrenia or patients with paranoia. That is something that I have had very good success with risperidone. Now, when it comes to mild, moderate, and severe, so studies have shown that cholinesterase inhibitors, which is basically those two categories, which is donepezil and memantine, these two have slowed the progression of dementia. It does not treat dementia, it does not cure dementia, it is just to slow the progression of dementia and to slow the progression of cognitive impairment. So if somebody has anorexia, meaning if their appetite is already bad, because decreased appetite is a effect of dementia, right? You want to stop donepezil because donepezil can also cause anorexia. So this is a very important thing because you'll find a lot of patients on donepezil, but their appetite is horrible. The first thing you want to do is stop donepezil. The next thing is if somebody is dizzy, you want to stop memantine because it can cause dizziness. That's one of the common side effects. When to think of advanced stage, we already discussed this, and it is FAST 7C. I'm also trying to look at the chat. The voice is very low. Okay. The starting dose for citalopram is 10 milligrams. We can start even as 5, but ideally we start 10. Okay, please tell me if you can hear me better. Sorry. I don't know why the volume is so low.
Yes, ma'am.
Yeah,
can
you
you-
are.
It's still low? Okay, you can hear
No,
me.
no, you are audible.
Okay, good. Yes.
Yeah, you are fine.
So when it comes to delirium, so what is delirium? What is the definition of delirium? Can anyone tell me the definition of delirium? Is anyone like able to? I think somebody already explained this to me once. Was it Parul?
Yes, ma'am. It's an acute
Yeah.
onset state of an altered sensation.
Yes. So there is something called AIDA in delirium. Okay, so that is actually like exactly. So it's acute. I is inattentive, D is disorganized thinking, and there's one more A. Why am I blanking out? 1 second.
Attention.
Yes, attention. Exactly. So acute, inattention, disorganized thinking. No, it's not attention. Sorry. It will come to me. But basically, that's the definition of delirium. It's a neurocognitive change in state. So there are 3 types of delirium. There's hyperactive, hypoactive, and mixed. Which is the hardest to diagnose? I'm sure people have seen delirium before.
Hypoactive is.
So actually, the hardest to manage is hypoactive. You know why? Because they are the ones that are never diagnosed. So hypoactive meaning they are very lethargic, they are quiet, there's no activity, they are very like, somebody with pneumonia comes to the hospital and they're very confused, but they're very lethargic. So that is hypoactive delirium. But the best part of the treatment of hypoactive is basically treating the cause. In delirium, the entire treatment is treating the cause. Now, just causes. There is a mnemonic for delirium causes. Drugs, like what? Like antihistamines, anticholinergics. These are very common for delirium. Digoxin can cause delirium. Electrolytes, like sodium electrolyte abnormalities, can cause delirium, as an example. Lack of drugs, withdrawal can cause delirium. Withdrawal of anything, SSRI, withdrawal of drugs, alcohol withdrawal, infection, pneumonia, UTIs. UTI is the most common one in elderly. Reduced sensory input. So it can also be, which is basically bowel bladder incontinence, urinary fecal disorders, intracranial disorders like stroke, myocardial and pulmonary disorders. These are all causes of delirium. Again, what is the treatment of delirium? It is just exactly the same as dementia when it comes to non-pharmacological measures. Again, you do not treat. So what are a non-pharmacological measures that we can use? Can anyone tell me what non-pharmacological measures they mean? So non-pharmacological measures are frequent reorientation. So if somebody is coming to you saying, I'm very confused, I don't know where I am, you reorient them and tell them they're in the hospital or they are at home. In the hospital, you want to put a clock. You put the clock, tell them what the time is. Is it morning or evening? So these are all ways of non-pharmacological measures. Another way, remove, any tethering. So if there's too many wires, too many, tubes, you want to remove all this. This would help. I mean, obviously, if oxygen is helping, you need to keep it, but avoid intermingling of all these things. Avoid restraints. So what does restraints do? It makes people more agitated and actually worsens delirium. The next thing is medications. So we talked about medications. It's pretty much the same thing that we use for agitation. Again, with the first line in elderly for delirium is Haldol. And Haldol starting dose is 0.5 milligrams. It is a very small dose that we start in elderly. Okay, now coming to second M. So before I go to second M, does anyone have any questions? And I have like 4 more M's, so I'll try to rush through the rest, but these are the most important. Let's see. Altered level of consciousness, yes. Acute change, yes, that is correct. Altered level is the most important, yeah. Okay, so when it comes to mobility, so what is mobility? How they move around, basically functioning, impaired gait and balance, and falls. Falls is very, very important. So how do you assess falls? So what is a fall? It's so important to define what a fall is, okay? So it's unintentional coming to rest on the ground or other level, not due to intrinsic or environmental cause, and without loss of consciousness. So if somebody loses consciousness, what is that called? It's syncope, not a fall. I mean, it's by definition. So why is this important? Why is fall so important? 30% of community dwelling adults over the age of 65 and 50% of those in long-term care will fall every year, which is a very, very high number. Why is fall important? It is. Unintentional fall is the 5th leading cause of death in elderly. People can die from falls. What is the highest risk of a fall? A previous fall. So a previous fall, if somebody has fallen before, that is the highest risk of another fall, okay? And this is the leading cause for SNF treatment. SNF is basically a nursing home, a skilled nursing facility. The leading cause is fall. If continuously somebody is falling, they end up in a nursing home. This is why it's important, because it can lead to fear of future falls. So in the US, it's been going up constantly. This is the graph of falls. So you want to assess, again, when you see the patient in the clinic, you want to assess for number of falls in 1 year, medications. Are there any medications that's causing them to fall? Can anyone name a medication that can cause falls? So benzodiazepines, right? So Ativan, benzodiazepines can cause falls. Okay, exactly. They can directly cause falls. And not just increase the risk, they can cause a fall. Another one is gabapentin that can increase the risk of falls. Then diphenhydramine, which is what? Which is Benadryl, what we use here. Diphenhydramine, antihistamines can increase the risk of falls. These are all some medications that can risk the falls. Then functional status and mobility, you need to know what their functional status is at baseline and how many falls they had in 1 year. So annually, you should be assessing, at least you should ask them, how many falls have you had in 6 months? How many falls have you had in the last 6 months? Why is this important? Because it will give you an idea of prognosis. If somebody has advanced dementia, what will happen? Their FAST 7 score will start progressing and they will start having more falls. That is how you know that their dementia is advancing. What do you look for an exam? Physical exam. Orthostatic vitals is the most important in falls. Most of the time, you will find blood pressure changes more than heart rate. So you want to tell them to get up slowly. Visual acuity. Most of them can't see at night. So you want to get them an annual vision check. Musculoskeletal. Parkinson's. You want to examine for Parkinson's, stroke, or even peripheral neuropathy. I cannot tell you how many patients who I've seen with falls have neuropathy. Gait imbalance, which is the right walker and cane. So a lot of times patients with Parkinson's, for example, there are different types of walkers. Not everybody has the same type of walker. So if somebody has Parkinson's, they have a problem with shuffling gait. So when they're shuffling and they use a walker with rollers, what happens is that they are not able to stop themselves. So so that's a risk of fall. So if you don't use the right walker, for example, if you're using walker with rollers without a brake, that can increase the risk of falls in a Parkinson's patient. Somebody who has, you need to give them an emergency call device, some device that, because if they've fallen, they won't be able to get up, right? So you want to be able to call some sort of emergency call device. And then cognitive evaluation. There's something called timed up and go test. This is a very clinical, very easy test. Basically, you make them sit, ask them, make sure they're using the right footwear, walker, all of this. And then you say, stand up from the chair. And then I want you to go. So now they walk on one line at a normal pace. And then they turn and then they go back and sit in the chair. So from the time they stand up, walk, turn, and then go back and sit at the normal pace is called timed up and go test. If it takes more than 12 seconds for them to do this, this is a high risk of fall. This is very, 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 very important. This is something we have to do pretty much if somebody has Parkinson's or anything. This will assess, this will show us that they need to start using a walker. So this is the summary of all the testing that needs to be done in falls. Now, again, in palliative care, we don't do all this, but this is something that, if we are doing testing, then we should be able to look for an EKG for arrhythmias, electrolytes, TSH, vitamin B12, vitamin D. Vitamin D is one of the most reversible, vitamin D and B12. They are reversible causes of falls. That means they are preventable. So high dose of vitamin D has actually shown to prevent falls. Then you want to do for X-ray because you want to look for arthritis, bone densitometry, which is basically a DEXA scan in patients above 65 years old, need a DEXA scan because you want to treat osteoporosis that also reduces the risk of falls. CT scan for strokes, echocardiogram for heart failure, EEG for a seizure, and vestibular testing for somebody who has vertigo. This is a fall risk modification. So very quickly, it's basically a summary of everything we discussed already. Something that's important is footwear. A lot of times footwear can also prevent a fall. New glass prescriptions, this is just something I'm going to skip. And this is another toe to head approach. So again, cognition, medications, cardiovascular, bowel and bladder, musculoskeletal, shoes, shocks, toenails. These are all forms to reduce the risk of falls. So, when it comes to falls, the treatment is all prevention, right? So you want to treat the cause, you want to treat the pain. A lot of people have pain and they're not treated. That actually increases the risk of falls. Physical therapy, occupational therapy is like so huge when it comes to falls because it reduces, it improves their strength. It causes DME, durable medical equipment. You want to de-prescribe. So remove benzodiazepines, sedatives, antidepressants, antipsychotics. One very important thing I've seen is diuretics at night. These old, when people are getting older, you don't want them to wake up at night and go to the bathroom because that's going to increase the risk of falls. So you want to reduce the diuretic dose, okay? Environmental, like bedside commode, lighting, non-slip bath mats, ophthalmology evaluation, osteoporosis treatment. Now I have a question. If somebody has atrial fibrillation, and they have a high risk, of stroke, do you want to stop their anticoagulation or do you want to continue their anticoagulation? Like what is the relation with falls? Does anyone?
Continue.
Why?
Arterial risk of embolism.
Exactly. The risk of embolism is greater than the risk of a subdural hematoma directly caused by an anticoagulant. So there is a study that shows it takes about 300 falls per year to cause a subdural hematoma. So the risk of stroke is much higher. So stroke can cause falls, right? So you don't want to stop anticoagulation. Then there is another thing is CBT to address the risk of falling. So they actually have fear of falling. So this is just a CDC home safety checklist that can be, you can look this online. It is actually very simple things that can be done to prevent falls. Slippery bathrooms, making sure they wear footwear at home, making sure there's no uneven steps, light bulb, like carpet. These are all things that can reduce falls. Now, very quickly, I'll go over the next few slides. Medications. So has anyone heard the Beers list before? So this is the Beers list. I'm just going to see a picture. I don't know if anybody can see this here. But AGS, American Geriatric Society, has a pocket card. It has these many lists. If I put this in presentation, it will never end. My presentation will never end. This is the list of medications that are under the Beers list, which is basically what medications you want to avoid in elderly. Some of the most important we talked about is benzodiazepines, Ativan, right? If somebody is on Ativan in elderly, you just want to get them off of it. Somehow get them off of it. Next thing is, by the way, another thing Ativan can do is called a paradoxical agitation. Ativan can increase the risk of agitation in elderly. So they actually, once the Ativan is off your system, they become more agitated. And then anticholinergics also can cause the confusion and urinary retention. Fourth M. The fourth M is multi-complexity. So multi-complexity is all the medical conditions. Basically, they have a list of maybe 20 diagnoses by 65 years old. So I'll just go a few things, okay? So this is important. In elderly, there is nothing called pre-diabetes. This is the biggest, misnomer because it takes years to develop. Patients die before they actually develop diabetes. That is the studies that were shown. The next thing is when it comes to American Diabetic Association, the target is less than 8%. So there is more evidence of hypoglycemia if you tightly control somebody's blood glucose in elderly. So the actual target is less than 8 for A1C and blood glucose of less than 200. In elderly, this is very important. Now, these are the trials, ACCORD and ADVANCE. Whereas in a hospital setting is different. There's ICU hospitalized, setting. There's, less than 140, 180 is what the number is. Insulin is usually used if the A1C is above 10% or blood glucose above 300. Avoid glyburide in elderly because it increases the risk of hypoglycemia. Don't start metformin on somebody whose GFR is less than 45 and it's completely contraindicated in less than 30. So this is a part of deprescribing when it comes to medications. Now, in palliative care, what should you know about diabetes? In palliative care, you want to minimize finger sticks. There is no point of poking them and checking the blood glucose 4 times a day. There is also, you want to reduce the once basal insulin. Try to reduce the insulin to 1 time a day and avoid hypoglycemia because that can actually kill faster than hyperglycemia. Hypothyroidism. In geriatrics, TSH up to 7.5 is normal. Don't treat subclinical hypothyroidism until the TSH is above 10. In cardiac, we talked about Eliquis, the geriatric age. Eliquis is basically apixaban. If it's about 2.5 milligrams BID, if the age is above 80. So there is a dose difference in geriatrics with Eliquis. This is the criteria. For above 90 years old, you don't want to start somebody on statins. There's no point of checking LDL or lipid panel for somebody who's above 90 years old because the time to benefit is beyond that. So it takes up to 3 years to benefit from a statin. The side effects can be beyond that. Now, in end stage, you want to know prognostication for heart failure. If somebody is short of breath at rest, despite maximal measures, their prognosis is less than 6 months. So heart failure, which is end stage, prognosis is less than 6 months. Prognosis for even end stage COPD is less than 6 months. End stage renal disease is less than 6 months. So this is important because the patients will come to you and say, doctor, how much time do I have left? That's a question that gets asked all the time. So then just going forward, the 5th M of what matters most. This part I will not be talking about because it's basically the rest of your palliative training. It's advanced care planning, advanced directives, healthcare proxy. It's the whole family meetings, how to conversation, how to communicate. Those are the most important things of what matters more. And a lot of it falls in what matters more, which is why that 5th M is covering all the 4 M's. What is the scope of geriatrics and palliative? Now, this part this is the models of care. Now, I'm going to tell you what I learned in fellowship, but obviously this is a little bit out of the scope when it comes to India at this point. I understand that. But I want to make sure you all are aware of what is available in the other side of the world. So in outpatient, we have geriatrics and palliative care clinics that are embedded. Okay. Then you have something called an ALIGN program. ALIGN is Aging Life Innovation Goals and Need for Complex Care. So patients with ALIGN, they have multiple ER visits or somebody who has extremely complex conditions. Acute rehab. So what is an acute rehab? What's the difference between acute rehab, subacute rehab, and long-term rehab? When do you put these patients in rehab? So if somebody can tolerate 3 hours minimum of physical therapy, they are a good candidate for acute rehab. So minimum 3 hours, okay? If it's less than 3 hours, it's subacute rehab. They're usually seen by nurses and physician sees them once a week. Long-term care is when there is out of the pocket where they're going to a new home. It's their new house. These are patients that are fairly independent. They can do at least their IADLs. There is something called geriatric ED where you try to put, the elderly patients in one side of the emergency department. MACE or ACE unit. So in my fellowship, we had something called MACE, which is called Mobile Acute Care of the Elderly. So we had a whole geriatric team that was just assigned to take care of patients above 65 years old. And ACE unit is studied and it's proven to decrease risk of falls, delirium, decrease morbidity, mortality, and shortens the length of stay. There's something called transitional care management, meaning calling the patient after 48 hours of discharge and asking them how are they doing. These are people that are allotted. We need a lot of manpower for this. Home-based palliative care. And then hospice models, these are different types of geriatric care also, whether it can be done at home, it can be done in residence, general inpatient settings, scattered bed. Hospice can be done throughout the hospital. And then there's palliative care unit, which is PCU. And now, if you want to become age-friendly, you have to get certified by American Heart Association here. It's called AHA, Age-Friendly Certification of Hospitals. This in general is the most important levels or different types of care in geriatrics and palliative care combined. And you can use my slides in the future, like if you're writing it down, I can just send you my slides. So an ideal outpatient or inpatient geriatric team. Now this is not true even at Mount Sinai. Like even at Mount Sinai, we struggle. Like even though they are the leaders of geriatrics and palliative care, we struggle trying to get this team. The first one is an MD, ideally geriatric trained, advanced care practice nurse, a behavioral health professional. We see so much geri psych in patients who are, dementia. Physical therapy, occupational therapy is a must. You need to also have speech therapy because they have risk of aspiration. Pharmacists will help you with medications that are not good for elderly. Social worker to help with complex psychosocial assessment. And then case manager to help with discharge planning, and then music therapy, massage therapy, registered dietitian, so many levels that can help in a geriatric. Now, how do you think like a geriatrician? This is something that, I want to make sure we take away from here. It's basically the summary of everything. medical, mental, physical, environmental, and care preferences. Different levels of care in geriatrics altogether put is how you think like a geriatrician. So here we give a card to our medical students. These are the 5 M's put all together into a card. Mobility, medications, mind, multi-complexity, what matters most. Okay. And these are my references. There's more. I have not fit everything, but there's more. Okay. So I hope I made it in time. That was a very quick, fast assessment of my 2 years of fellowship. So I apologize if I couldn't cover more, but
Yeah,
yeah.
thank you, Dr. Rosmy. And I think she has done a good job in the available time to sensitize us regarding the most important things in geriatrics, dementia, then delirium, falls, which is very important, and some of the screening tools and introducing fast and things like that. So I think uh, we have to actually put it into a practice, then only we will know more about it. So
Yes.
we can open the session for discussion.
I mean, if you ask more questions, then I'll perform. Let's put it that way. So how has everybody's experience been with geriatrics and palliative care? Like, do you see geriatrics being used in palliative care? Do you have any like
So
experience?
we see a lot of cases. Actually, in our statistics, we have about 45% of cancer patients, and rest are non-cancer patients. And if we take all together, at least 60% are above 65 years. And as of we do see a lot of geriatrics patients and dementia. We actually started some comprehensive geriatric assessment, which include things which you have already mentioned, like clot test, things like that. So that's about us, but many of the political institutions in India are mainly focusing only on cancer palliative.
Yeah.
So,
Yeah.
so
So
that's
yeah.
something.
So there was one, that's a very good point actually, because at Mount Sinai, one of the reasons I did my fellowship at Mount Sinai is because they focused on both cancer and non-cancer. So when you see geriatrics, you have to see the entire spectrum, right? But you're right. Actually, when you think of the leading causes of death in geriatrics, number one is heart disease. It is still heart disease. Number two is actually cancer. And now cancer is very close to heart disease. The amount of deaths because of cancer is very close. So stroke is actually also one of them, and then falls. So when somebody had asked a question about just to assess advanced dementia and use of syndopa in dementia when they actually have not much of Parkinson's symptoms, neurologists try many medications, slowly adding and reducing some on and off. I really don't get it sometimes. Can you please enlighten? Thank you. So this is very important. I have seen Parkinson's come at advanced stage, started on syndopa, and I have seen undiagnosed early Parkinson's that was just diagnosed, started on syndopa. So in advance, so really depends on the stage of dementia. So you guys remember the FAST scale, right? The FAST scale is primarily used in Alzheimer's, but it can also be used in Parkinson's dementia. The way we use it is if somebody cannot swallow, has difficulty aspirating, if somebody is difficulty aspirating, cannot speak, if somebody is immobile, like they're staying literally bedridden, there is no benefit of Syndopa at an advanced Parkinson's stage. Syndopa only, which is carbidopa, levodopa, only affects mild to moderate Parkinson's, and it only slows the progression of the disease, just like Alzheimer's. Once it's advanced stage, once it's advanced Parkinson's, it is mainly palliative care, it is mainly symptom management, including behavioral disturbances, trying to reduce the risk of falls. Now, in early Parkinson's, when you start them on Syndopa, it slows down the rigidity. So the patients are very rigid, and when it slows down the rigidity, they help with mobility. So in the early stages, they actually decrease falls, they actually increase their mobility and their cognition. So I would say if somebody is moderate to severe stage based on the FAST score, you can cut it off because it can cause also sedation. That has been my experience. I hope I answered that question. Vitamin supplements and other nutrition supplements. So vitamin D, pretty much everybody should be on. I mean, it's a pandemic. Everybody's low in vitamin D, right? You want to check this because we have seen like decreased risk of falls with vitamin D supplementation. Vitamin B12, you want to check if somebody's anemic, if they're macrocytic, you want to check vitamin B12, somebody peripheral neuropathy. Vitamin B12 is very easy. They can get the supplements or they can take the injections. So these are two supplements. Now, there is no study that has proven multivitamins. They've said multivitamins is like of no use because it actually goes through the urine. I mean, it is a water soluble. So the only addition of vitamins is only recommended if somebody has a very poor diet. So if somebody is not eating at all and like, not eating properly, then maybe there's a benefit of adding a multivitamin. But otherwise, there is no evidence of adding multivitamin. In fact, it can cause polypharmacy. So polypharmacy is what? Polypharmacy is taking more and more supplements when somebody has a difficulty swallowing. You want to reduce the amount of medication. That is your goal in geriatrics. It's deprescribing. So even if you find a patient who comes to you with 10 different supplements, tell them to take one multivitamin and cut it down. Like that is the first thing. The second thing is all of this is dietary. So you can always increase your iron intake, you can increase your, nutrition intake. You can go to a nutritionist, somebody who can help you with the diet. So I would say in elderly, less is better. Less is more. Is there any other questions?
Can you talk about start-stop criteria? Start-stop criteria.
Start-stop criteria. Is that for, I'm not sure of that one. Is that?
Okay.
I'm not sure if it's here, it's different here. Yeah, actually, this is, it's the same thing. It's the same thing. So start, stop, and I'm also looking it up, but at the same time, I'm trying to figure out whether it's a different term here. But here, start, stop is basically screening tool for older, stop, which you were asking, is screening tool for older person's prescriptions, which is stop. And start is screening tool to alert to right treatment. So that is start and stop. It is basically deprescribing and prescribing the right medications. Now, one thing very important in stop is when a patient comes to you in a hospital. So for example, a 65-year-old comes in with dementia, uses a pill box at home, a pill box with, 1 week supply. And it is being done by the daughter, not by the patient. And they're coming to you and they're come to the hospital and being admitted. The most important thing is medication reconciliation. So medication reconciliation is one, confirming with the daughter and the patient what they're taking. Most of the time, you'll find 2 bottles, exact same thing, they're taking twice. That is the stop criteria. That is where you have to stop. Second thing, you will find expired medications. Third thing, you will find medications that are counteracting with each other. You will find a person on Lasix and oxybutynin. Does that make any sense? If you're on a diuretic and something to prevent urinary incontinence, they're against each other, right? So this is very, very common. Somebody who is now, for example, opioids. Now, if somebody's on an opioid, the first thing they need to be is on what? If somebody's on an opioid, they need to be on a bowel regimen, right? Because opiates can decrease the risk of, it can it can cause constipation. So if you find somebody on a constipation medicine and loperamide, which is Imodium, I'm telling you, these are very common. You'll find these so deprescribing is stop criteria according to, the term. I didn't learn it as stop, but it's pretty much the same thing. So the next question was hyponatremia in patients with SSRI and multi medications, how to reduce? Can we just increase the salt in diet? So yes, first you can find out, first you have to actually confirm the diagnosis of hyponatremia with SSRI. So, and also the degree of hyponatremia. So if somebody's sodium is 130, 131, 132, you don't stop the SSRI because the benefit of SSRI is better than the risk of hyponatremia. So you don't stop it. But if somebody's having acute hyponatremia less than 130, you would switch or you would change, the medication. You can consider other medications. Now, also studies have shown there's one, I think it's paroxetine. There's one SSRI that is the lowest risk of hyponatremia. So you can consider that. And multi-medications, how to reduce. So I wouldn't, so increase salt in diet really depends on the situation. So if somebody has heart failure, I would not reduce this, increase the salt in diet, right? So I don't think, no, it takes a few weeks, like up to 6 weeks for that hyponatremia to resolve. So increasing the salt in diet can, it can take some time. How to treat insomnia in which is very common in geriatric age while addressing the risk of fall at the same time? That is a great question. So here there is something called melatonin. I think in India also we use melatonin, right? So this is the first line for insomnia. Actually, I take that back. No, first line medication for insomnia. But the first line treatment for insomnia is a sleep hygiene. So what is sleep hygiene? Stop the phone before you go to sleep. Okay, that blue light is going to affect your sleep pattern. It is going to affect your sleep pattern. What's the next thing? Having a sleep regimen. Some people sleep at 1 o'clock and wake up at 5 o'clock. That is not a sleep regimen. They have to have a sleep routine. What time you eat your dinner? What about the noise in the house? What about, so much of it is sleep hygiene. And they have something called cognitive behavioral therapy for insomnia. Literally, therapy helps to prevent insomnia. So medication, again, is not the first line treatment for insomnia. It's actually sleep hygiene. Another thing is to reduce stimulants. Some people drink coffee at 8 o'clock at night. You want to reduce that. Like, you don't want to drink coffee at 8 o'clock at night. So these are things that will reduce insomnia. The next thing is melatonin. The next thing is non-benzodiazepines. There's something called non-benzodiazepines that is for insomnia. I would say mirtazapine. Mirtazapine is a very, very good medication that can be used for insomnia at night. It is started at 7.5 milligrams, and it is the lower dose is more sedating. So if you want to increase appetite, it starts at 15 milligrams. But if you want to cause insomnia or like sedation just to sleep, you start at 7.5 milligrams. Almost, if you are if there's a cancer patient, there is less evidence of mirtazapine. But if you're not a cancer patient, then 7.5 milligrams of mirtazapine as a good dose for insomnia. What is the reason for persistent hyponatremia in some elderly patients? That is a great question. So really, most of the time, there can be even malnutrition, really. So heart failure is a very common cause of hyponatremia. Then chronic liver disease. can cause hyponatremia. Then alcohol. So there are so many external causes of hyponatremia, but most of the time it can be even just malnutrition, like low albumin states. So sometimes you can try to increase the dietary salt intake and see if there's improvement. It can also cause orthostatic hypotension, this low salt situation, and that can also decrease the risk of falls. Okay. Any other questions? I hope that was helpful. Can dementia and brain atrophy as such cause hyponatremia? I don't think so. I have not heard of that before. Dementia alone causing hyponatremia? I would say it actually is the other way around. What I've seen is hypernatremia with patients with dementia, because when there is decreased PO intake, where there is decreased, there's dehydration, there is decreased intake, they become dry. So their sodium, when they come to you, it's like 160 when they come to you. So I've seen it the other way around. It's not lower, it's usually higher. Usually hyponatremia is usually a sign of cancer. It could be SIDH, heart failure, chronic kidney disease, all of that. Yeah. But I would say if the dementia and hyponatremia is there, usually like, I haven't seen that, sorry. I mean, I don't know. I don't think that's true. Okay.
Any more questions? Parul is eagerly waiting for your performance.
Okay, well, I'm happy to share. I have managed to sing for my patients here. I've actually had a very good experience in hospice with music, and I've also had experience in geriatric with music.
Yeah, can you talk about music therapy and
Yes,
when
yes, I'm happy to. So how is music therapy different from music? So just playing music is not music therapy. Music therapy is aligned with their goals to bring a reduction in a symptom. So for example, pain, you want to reduce their pain from level 10 to level 7 with the help of music therapy. That is a music therapy goal. Anxiety, I want to reduce anxiety from severe to moderate with music. Not just playing music, okay? Now, music therapy is a 4-year degree in America. And it is actually assigned based on, I think it's called environmental music therapy, where they choose music based on their symptoms, based on exactly what they want to alleviate. So I have seen music therapy consultants. They come into the room and it's usually a 20-minute session. And they look for before and after. They record the breathing, the heart rate, and then they go based on, if there's improvement. Mostly music therapy is seen for behavioral disturbances when it's mild. Advanced music therapy does not help. So obviously, if somebody's agitated, you don't want to be playing music because you have to treat them with medication, right? So this is what I mean. Like, it's very important when to use music therapy and when not to use music therapy. So just to give an example, so I had a patient with ovarian cancer who was a musician, and she's end of life care, and she's in hospice, and she's on opiates, and she did not feel good in life. She was just like, I don't feel good. Like, her pain is resolved, or even at least 2 out of 10, but so we discussed about music. And then it's called a musical history. actually you have to take a history of the patient's music interest. And I asked them, she liked some old classics in English, and she liked Bill Withers' Ain't No Sunshine When She's Gone. And I sang that for her. So I don't mind singing a few words of that, actually, since we don't have. Sorry, I'm just taking the lyrics. Apologize. Ain't no sunshine when she's gone. It's not warm when she's away. Ain't no sunshine when she's gone, and she's gone away too long. Anytime she goes away, wonder this time where she's gone. Wonder if she's gonna stay. Ain't no sunshine when she's gone, and this house just ain't no home. Anytime she goes away. So that's a very common. Okay,
Thank you so much. It was so beautiful.
Oh, yay. I think I got more claps for my music than for my presentation.
No.
Joke.
Okay, I think that was just song was the most but we can conclude that it is a beautiful song. And Dr. Rosmy, where are you from in India?
So I'm originally from Kerala. I'm a
Okay.
Malayali. But I was born and raised in Kerala, but raised in Abu Dhabi, and Indian school and everything. But I did my medical school in Bangalore. So I learned many languages. I learned Malayalam, Kannada, my dad is from Neyveli, so I learned a little bit Tamil, Hindi. And then I came here, and then because I grew up in Abu Dhabi, I had to learn Arabic. And then I come here and I had to learn Spanish. So people look at my CV, they're like, my goodness, like, so many languages. Yeah, but it's just, you have to learn languages in India. But thank you. Yes, I'm from Kerala.
Thank you, Dr. Rosmy, for this wonderful session as well as for a wonderful song.
Yes.
And, I think all of us actually enjoyed both. So looking forward for more sessions from you. Definitely, we have a lot of teaching programs, so we are going to call you again for teaching programs.
Yes, thank you.
Thank you for coming. Supriya, it's all to you.
Thank you, Dr. Rosmy. I think for 28 sessions, we had to wait for getting this bonus from a speaker. That was so awesome for closing us talk during, especially during the late evening time. Thank you so much. And being a non-medical person, I really enjoyed the last singing part, absolutely. And it was like, very astonishing to hear that you know so much languages and you are doing so great. Thank you so much. I believe everyone here would be interested to check out on your YouTube channel as well after this session. Yes, I can see Dr. Parul and Dr. Jabra already giving thumbs up. So of course, maybe you can expect a slight count in the number of subscribers after this session. Thank you once again for joining us and walking us through a very, very important topic as well, a topic much connected with palliative care. And with the gently reminding that tomorrow also we'll be having another topic, a very interesting topic, and another eminent speaker joining in for the evening. This is Sri Priya, along with Dr. Rosmy Jimmy and Dr. Sunil Kumar, signing off from the Palliative India's presentation desk. See you tomorrow, same time again. Till then, everyone take care. Bye-bye.